Hi everyone, how are you? Welcome to another video on recalls. Here, this is the January 2023 recalls. So, first of all, let's see the question. Patient on warfarin, that means the patient taking warfarin and started to bleed. What is the use to measure the bleeding? That means they want to know actually the mechanism of action of warfarin, or warfarin acts which of the following factor. Here the options are deficiency of factor 27910, prothrombin deficiency, platelet deficiency, deficiency of factor 10, and deficiency of factor 7. So we have to find out the action of one warfarin on which of the following factor. For this, they start bleeding. That means the warfarin, the dose of the warfarin is more increased. So deficiency of the some important factor for this bleeding occurs. So first of all, let's see the warfarin. Here, this is the normal pathway of coagulation. Here we can see the intrinsic factor and extrinsic factor. The intrinsic factor, it is longer, and extrinsic factor, it is relatively smaller. And intrinsic factor, here we can see factor 11, factor 12. First of all, activated by the contact factor, and the activation on different pathway, and finally G, clot develop or coagulation factor activated. And here we can see different actions, as here we can see the warfarin, and warfarin acts the four important factor. Here we can see this is 2 7 9 10. So the warfarin, it acts on 2 7 9 10. It is the large pathway, or it acts on the four important factor to prevent coagulation. And the other factor, here we can see the enoxaparin and heparin. Here we can see this is the enoxaparin and heparin, it acts on this pathway. And also the epixaban, endoxaban, and rivaroxaban, they acts on the factor 10. So this point is very important. That means the recent anticoagulant, which is the epixaban, endoxaban, and rivaroxaban, they acts on factor 10, or activated factor 10. And as these anticoagulant acts on only one factor, so their side effect is relatively less. On the other hand, the warfarin, it acts on the four factors. This is the 27910, so their side effect is relatively more than that of the newer anticoagulant. And also here we can see the enoxaparin and heparin, they acts in these two pathway, which is the factor 10 and factor 2. This is the, here we can see the heparin, the mechanism of function of the heparin. It acts on extrinsic pathway. Here we can see the extrinsic pathway coagulation, and it acts on this point, and it prevents coagulation and thrombosis. So finally it is ready. Then in case of warfarin taking patient, here this is the warfarin taking patient, there is deficiency of the factor 2 7 9 10. Prothrombin deficiency, it is not here. Platelet deficiency, not here. And other factor is not related to warfarin. Then a female with rheumatoid arthritis, here we can say RA, which is the rheumatoid arthritis. That means the patient is suffering from the rheumatoid arthritis, and the patient also bronchial asthma, and she is taking 10 milligram BID, that means 10 milligram twice daily steroid, and also salbutamol. And she developed right iliac push-up pain and vomiting, fever, potassium is high, and WBC more than 15. That means if 15,000, sodium is low, blood pressure 80 over 50 millimeter mercury, pulse rate 80. What to do? So a patient, or a female patient, which is who has the rheumatoid arthritis and bronchial asthma, and she is taking steroid twice daily, suddenly develop right iliac push-up pain, vomiting, fever. That means it is fissure of the acute appendicitis. And WBC count 15, that means it is infectious, so it is the acute appendicitis. But sodium low, blood pressure is very low, pulse rate 80. So what to do? So first of all, we have to increase the blood pressure, but we have to realize that the patient is taking steroid. So what is our option? The options are the 250 ml colloid and reassesses, 100 ml prednisolone, 1 0.2 gram IV co-amoxiclav, IV 100 milligram hydrocortisone, and calcium rhognium per rectum. So what will be the option? Here we can see the decreased blood pressure. Usually for increasing blood pressure we use the crystalloid solution or colloid solution, but here we have to remember the patient taking steroid. So in case of taking steroid patient, suddenly if the patient suddenly develop any trauma or any accident or any infection, in this case the there is deficiency of the adrenal gland to release of the cortisol. So for this patient we have to give steroid. So now see the adrenocortical suppression. The adrenocortical suppression who is what when occur? It occurs when there is steroid supplementation outside the body. So here we can see the patient receiving oral adrenocortical steroid. In this patient adrenocortical suppression develop, and before any operation or in a crisis moment, all patients should be asked about the dose and duration of the steroid. And extra doses of the steroid pre-operatively use so as to avoid the Addisonian crisis. And this also uses in case of the, it also applicable in case of the emergency crisis for the patient. Any emergency crisis such as infection, such as the road traffic accident, and any other cause which causes emergency, in this case there is chance of develop Addisonian crisis. That means there is the adrenal gland fail to release the cortisol. So a patient taking more than 5 milligram prednisolone equivalent within a month of the surgery. So a patient takes more than 5 milligram steroid within the 1 month. In this patient, there is chance of development of the adrenocortical suppression, and in this case, we have to supplement the steroid in IV form. So we'll require supplementation at induction and post-operatively. So this point is very important. That means the adrenocortical suppression patient, if we suspect, then in this case during induction, that means the pre-operative period, or during the infection, or during the just after the road traffic accident, we have to give induction of the steroid, and at the and then maintenance, that means at least 2 to 3 days supplementation of IV steroid. So here in this case we have to supplement the IV steroid, which is the hydrocortisone 100 milligram IV initially given, and maintenance dose up to the 3 or 4 days. Then we can see a 70 years old male, angina on going upstairs. Echocardiography was done. What is the most likely findings? So first analyze the question. Here we can see there is this 70 years old male, angina on going upstairs. That means when workload increase, that means when a man going upwards, he needs more blood, and he needs pumping of the heart more rapidly. Echo and ECG was done. What is the most likely findings? Here the options are aortic stenosis, aortic sclerosis, aortic regurgitation, mixed valvular disease, mitral stenosis. So if a 70 years old male, if aortic stenosis develops, so in this patient suddenly loss of blood supply, so there will be frequently fainting attack or unconsciousness develop. There is no clinical feature. Then aortic regurgitation usually gives not such type of symptom, and other options such as mixed valvular disease and mitral stenosis, they are not related to this. And here the age is very important, as it is the 70 years old. So there is development of the atherosclerosis, because in advancing age there is development of the atherosclerosis. So during this, that means in case of 70 years old man, there will be developed aortic atherosclerosis. Here we can see this is the aortic sclerosis. So our answer is the aortic atherosclerosis or aortic sclerosis in this patient. And other options such as the aortic stenosis, aortic regurgitation, mixed valvular disease, and mitral stenosis, in this patient the murmur will be present in the question. So that is no fair to answer this question. In case of any valvular heart disease, there will be definitive murmur or type of murmur in the question. So don't worry about the other options such as the valvular option, because in case of valvular heart disease, the murmur and murmur type will be definitely present in the question. Now, question number 9. 8 years old child become tired and breathless after playing football, brought to by ma'am, harsh continuous murmur under the left clavicle. What is the diagnosis? So here, for important questions such as 8 years old, that means it is a younger child or early life. The uh, boy or the child is early age, and he or she is tired and breathlessness after playing football and brought mom by harsh continuous murmur. So this point is our important. That means the continuous murmur, and it is placed in the under the left clavicle. So we have to find out the diagnosis. First of all, it is a small child or younger child or early life. So it is usually congenital, and it develop continuous murmur, and the murmur is located under the left clavicle. So what will be the answer here? The coarctation of the aorta, patent ductus arteriosus, ventricular septal defect, atrial septal defect, and transposition of the great arteries. So now see, so first of all, let's see the coarctation of the aorta. The coarctation of the aorta, the clinical examination of the pulse may demonstrate radiofemoral delay. So in case of coarctation of the aorta, that means the narrowing a part of the aorta, and in this case the upper limb gets more blood and lower limb gets less blood. So in this condition, radiofemoral delay develop. Then here we can see a murmur is continuous. So this is our another option, that in case of coarctation of the aorta, the murmur is continuous murmur, and it is heart based over the thoracic spine below the left clavicle. So here we can see below the left clavicle, the murmur of the coarctation aorta is right. So here we can see the coarctation of the aorta. Here we can see the part of the uh, aorta, it is narrowing, which is known as the coarctation of the aorta. So this picture is taken from the Balian Love surgery book. You can take a look in Balian Love. So our answer is the coarctation of the aorta, because in case of coarctation of the aorta, there is murmur which is the under the left clavicle, and it is continuous type of the murmur, and as it is congenital, because the patient is important. Now, Primi gravida, 24 years old, third trimester, chest tightness, cyanosis, congested neck vein. Her father died at 60 with myocardial infarction. So though this scenario is not incomplete, but it is easy for us, that primary gravida, that means the 24 years old. So pregnancy is one of the cause of the development of the thromboembolism or pulmonary embolism, and during the third trimester, that means in the late stages of the pregnancy, chest tightness, cyanosis, congested neck vein develop, and her father died of myocardial infarction. So what is the cause? Causes here: aortic dissection, acute pulmonary embolism or massive pulmonary embolism, myocardial infarction, pulmonary infarction, and lung cancer. So we have to find out one of the options. Here we can see the pulmonary infarction and lung cancer. Usually in case of 24 years old, it is not typical, and the AMI or myocardial infarction, in case of myocardial infarction, chest tightness, cyanosis, and congested neck vein, they usually absent, and in case of younger is it usually not present. And other options such as aortic dissection and pulmonary embolism. So this two option is important, but aortic dissection, it also occurs in the later stage after the development of the atherosclerosis. So now see the pulmonary embolism, the different type of the causes such as the stroke or recent MI, atrial fibrillation, myocardial infarction, recent surgery, estrogen therapy, disseminated malignancy, pregnancy, and postpartum. So, in case of this patient, such as the estrogen therapy and pregnancy is uh, important, and in case of this patient, only pregnancy is the most important cause. So, sign symptom of pulmonary embolism. Here we can see the sign symptom are similar to the question. That means it is the dyspnea, chest pain, cough, hemoptysis, right heart failure, and cardiogenic shock. So, our answer is the acute massive pulmonary embolism. Thank you all.